Welcome again. So I'm Mariangela Pellegrini. I work for the European Reference Network on Rare Hematological Disease. And I'm very glad to welcome you on behalf of the ASCAT and EuroBloodNet. So as you may know, this project of bringing therapeutic patients education at the core of ASCAT started 4 years ago in 2019. And since it's been such a pleasure to see how this group of people connected together, work together, strengthen the collaboration among clinicians and people living with sickle cell disease, sharing best practices, experience. And so during this day, this year, we talked about racism, mental health. Yesterday, we talked about pregnancies. And tomorrow it's the last session. Then we will have the plenary of the ASCAT when 4 people that participated to these 4 sessions will present the outcome. So I will recommend not to miss that moment. It's tonight at 7:45 UK time. So I will now pass the floor to the moderators of today's session for introducing you the topic and the speakers, and thanks to everyone.
Welcome everybody to this session. We've had, as Mariangela introduced, had an excellent previous 3 sessions dedicated to improving the knowledge or knowledge transfer between patients and physicians, I feel. So we as physicians have learned a lot from patients, and I think we hope that patients have also learned a lot about the condition. And the 4th of the series of presentations that we've had, we hope that this is going to be one of the memorable ones, really, and excellent discussions went on in the previous sessions. So today's topic was also, like the other 3, today's topic was also based on patient feedback on what they wanted to hear about. And we have, therefore, on the basis of what patients have fed back, arranged this conversation between patients and we're very lucky to have an expert who does this work on a daily basis. So today's topic is bone marrow transplant in sickle cell disease. And with me, my co-moderator is Agnes Nosefua, who is going to also help us moderate this conversation. It's going to be, hopefully, a very free-flowing conversations. So we have 2 patient experts and 1 physician expert here today to talk about this. So I've been asked to introduce 2 experts, 1 patient expert and 1 physician expert. So my patient expert is Constance. Constance is a pharmacist by training, but he also is the president of the Doris Sickle Cell Association, and he's currently in Benin actually, and has linked on the Zoom platform from Benin, but is normally based in Strasbourg. So very welcome to Constant. He's going to talk to us about from a patient perspective and a user perspective, the bone marrow transplant. And it also gives me great pleasure to introduce Professor Marco Zecker. And Professor Zecker is the director of the Pediatric Hematology and Oncology and BMT unit at the University of Pavia in Italy. He's the past president of the Italian Association of Pediatric Hematology and Oncology. He's a member of the European Bone Marrow Transplant Inborn Errors Working Party. I'm told, he's a passionate physician who collaborates with Italian patients associations. He's an expert in haploidentical transplant in sickle cell disease, as well as, of course, all other types of transplant. And he co-authored the BMT guidelines in the sickle cell disease Italian national guidelines. So ladies and gentlemen, you are in very expert hands. I will now share the stage with Agnes to introduce the rest of the speakers.
Thank you so much, Savannah, for that. And thank you, Mariangela and the team for ASCAT. Thank you for inviting me for the third year again to come and be part of the patient session. So my name is Agnes Nsofa. I'm a global sickle cell advocate, founder and executive director of Australian Sickle Cell Advocacy. I also founded Amplify Sickle Cell Voices International and Zambia Network for Sickle Cell. Over 13 years ago, our daughter was diagnosed with sickle cell anemia at the age of 14 months. Her diagnosis was what prompted me to start advocating for sickle cell disease. Bone marrow transplants were introduced in 1982 as an option for the treatment of sickle cell anemia. However, this is costly and comes with complications. An article dated 2015 estimated the cost of the transplant process for most patients to be between $150,000 to $250,000 US. Today, this cost is more than this. This treatment option is widely used for both adults and children globally. However, due to the high costs involved, it is not readily available for the majority of patients in the sub-Saharan Africa, where the disease burden is extremely high. In 2019, our daughter became the first child to receive a bone marrow transplant to cure sickle cell anemia in Australia. Lucky for us, the Australian government paid for this treatment. As a parent, the 2 years we spent to prepare for this treatment, plus the 40 days we spent in hospital, were the most stressful period of my entire life. I've asked my daughter to express herself how she felt during this period, but she refuses to share her experience as she's a 13-year-old girl. Today, we have Luz Sano, an adult who underwent a bone marrow transplant, to share her experience. Luz is a sickle cell advocate from France and is very involved in the association she dedicated to bone marrow transplant in sickle cell. Please welcome Luz to give a testimony about bone marrow transplant. Thank you.
Yes. Hello, everybody. My name is Luz Kosekesona. I'm from Paris. I live in France. I'm going to tell you my story, my journey with sickle cell disease, and my recovery by bone marrow transplant as an adult. For me, my story began pretty well. A smooth birth, at least for me. I was a beautiful baby and calm, playful, anything you would expect from a normal child. Suddenly, I don't sleep at night anymore. I cry all the time. It's impossible to calm me down. They are my first crisis. The diagnostic come out very fast. The doctor had a very bad news for me and my family. They are giving me only 3 years to live. But they didn't know me well. I was stubborn, I was a warrior, I was determined to beat this odds. Of course, it was painful reach, 5 years old. So my parents did fight as well because they managed to bring me in Europe to get a transplant, my best chance to survive. Unfortunately, things were stacked against me, and no one of my siblings was 100% compatible for transplant. On top of it, I can't go back home anymore. I'm too sick to travel, and I have no other choice than staying in France. I thought the worst I could live was the crisis on cold weather, but I didn't know yet that SCD is an evolutive disease and that I will have to face terrible complications. An extremely painful crisis, a stroke that left me paralyzed on my left side. I look like Two-Face for weeks. I don't even talk about the gallbladder surgery and the chest syndrome. I've been given all sorts of treatments, hydroxyurea from 9 and transfusion following the strokes at 12 years old. I received blood for 19 years. Every 4 weeks, sometimes more, I was a real vampire. So you can't live with this disease. You barely survive. It's a perpetual race for survival and on all psychological and physical, social, emotional fronts. It's unbearable. SCD handicap you in everything you do. Study, work, relationship. It's hard to wake up in the middle of the night with a nutritious pain impact all your life, as well as the life of your close one. The turning point in my story was the birth of my daughter. The crisis doubled in intensity and numbers. My arteries were damaged. Morphine no longer has an effect on me. I have to use ketamine. I had 6 implantable venous access devices with which all led to major septicemia. I was hitting rock bottom. I felt like there was no tomorrow anymore. I thought my next crisis will be the last. Fortunately, medicine was progressing hugely. I was about to lose hope when a miracle happened. I found the transplant trial in UK, and I did everything to be the first patient in Europe to experiment this new technique to heal. Back then, there was only a survival rate of 50%, and you know what? I survived. The transplant went well. I was anxious because even if I was familiar with being at the hospital, I didn't know chemotherapy, raise, and sterile room. Not being able to take a real shower, food restriction are really nothing compared to GVHD and chemo secondary effect. I was expecting hair loss, but it's still a shock. When they told me I was cured, it seemed so surreal to me. And anyway, I still have a long way to go. Surprisingly, it was not the end of my trouble yet. I used to think that healing physically would be the end of my pain, but then I realized that I have to rebuild myself from the inside. I didn't know who I was anymore. I didn't know how to create a normal life. The basic things I didn't know. The SCD put me in survival bubble, and when the bubble bursted, I was lost. The aftermath of transplant was also a trial. My whole body resetted. I have to redo all my vaccination, continue the anti-reject drugs. I have never felt so fragile and vulnerable than during the 3 first years. I was exhausted and lost, but step by step, by looking for and meeting the right people, I got off of it. Now, with my experience and expertise, I had created a sickle cell pain training to understand the specific functioning and the avoidance strategies with visual and sound tools. I managed to perceive painful crises and make a link with a no pain. I also accompanied transplant patients with a coaching and mentoring program. But my goal this year is to make my therapy education book for sick and disabled children. Uh, in conclusion, the bone marrow transplant saved my life. I'm convinced that transplants have a decisive role to play in this fight against SCD. Thank you. Sorry.
Thank you very much, Lise. Can you hear me? Can everyone hear me? Yes, wonderful. Finally managed to sort out the audio problem. I was wanting to introduce introduce Constant or invite Constant to talk about his viewpoint about bone marrow transplant and sickle cell disease, please.
Thank you so much. Thank you for the organizer of this Congress, and thank you to invite me. What can I say? My history about sickle cell began when I was working my thesis. I have a PhD in pharmacology and biocell. And one day I heard about sickle cell disease, and I tried to know more about sickle cell disease. So I make a plan, I make a project, research project, and association project to help sickle cell disease. But three years after, I know that my child was sickle cell. So these helped me to go on to work about my project, research project and association project. It's very difficult when you have a child with sickle cell disease, and you can observe the child, and you understand that you don't have the power to hack. In the family, we decide to stop about baby. And like one day we expect another baby, and we make screening before we make it class, and not the same way in English and in the same word in English. And we know that the children who will come, the child who will come is not free for sickle cell. So that's a good news. But a few months later, the physician called us to announce that she is compatible with our other children who have sickle cell. So that's a good news. But I observed that it's not easy. 15 years ago, it's not easy to make a decision. That's good to have someone who can help your child, but you hesitate because you don't have a good news about sickle cell, about transplant, and you're afraid to, if you don't, something happen with your child, it will be not easy to, it's not easy to manage. But my child, she was very, very sick, and we must have a decision, and we decided to give her a chance to transplant. So the day came, and we went to the hospital to make this transplant. One thing I want to say about that is when you have a person, child or adult, who must make these acts, medical acts, it's very important that to tell to these people every step of the process is very, very important. So our child, we tell her about everything we know about the process. This helped us when the bad moment came at the hospital. We can tell her to remember, we told you that at this moment you will lose your hair, you will, yeah, she knew everything about the process. And this is very important. But something about parents is we are all time stressed during this process, because one thing you want to hear is that everything going well. But it's not very easy to have everything like in the process. But another thing who help us, who help parents, is the mentality of our child during this process. She always fighting. She always tell us that she will want here, she will heal, and went at the hospital. So this helped us to manage the situation. And after 1 month at hospital, we observed that everything goes well. So we leave hospital with her. So this is my short testimony, and I'm able to answer questions if people have questions. Thank you so much. Do you hear
Thank
me?
you very much. Thank you very much, Constant. Your the beginning, there was a little bit of disturbance on the internet, I think. But I think towards the end, we were able to hear you quite clearly. So thank you very much, both Toulouse and Constant, for their very nice perspective. I'm sure we'll come to a lot more. We'll unpack a lot that has been said already. And further to that, we will ask Marco, Professor Zecca, to also give a physician's perspective to the bone marrow transplant. Agnes, was there anything else you wanted to add in at this point before we introduce, ask Marco to talk?
No, not at all. I think the best option would be for the expert presentation, then we can go into questions. Thank you, Savannah.
Okay, lovely. So Marco, over to you. It'd be really great to hear from your point of view. Eager to hear what you have to say.
Okay, thank you. I'm sharing my slides, just one moment. So I am Marco Zecca, and I'm a physician, and I'm mainly involved in allogeneic stem cell transplantation in non-malignant disorders such as hemoglobinopathies and especially sickle cell anemia. And I have prepared some slides for a brief talk of about 10 minutes, 15 minutes, no more, just to give you an idea of what a stem cell transplant is and the results, the current results of the procedure, as well as the possible problems and the difficulties. So as we know, allogeneic stem cell transplantation is a quite complex procedure. I have tried to summarize it in this slide, and the aim of an allogeneic hematopoietic stem cell transplantation is the replacement of the patient defective hematopoietic cells with healthy hematopoietic cells from a healthy donor. So this procedure can be, this aim can be achieved using a so-called conditioning regimen, that is a combination of different chemotherapy drugs, and in some selected cases also of radiotherapy that are necessary in order to do what is called marrow ablation. Marrow ablation is a condition that we have to achieve. We have to destroy all the stem cells present in the bone marrow of the recipient in order to allow the engraftment of the donor cells. So this is the conditioning regimen. Then we have a healthy donor that can donate either bone marrow cells or peripheral blood stem cells. And the availability of a donor is regulated by a set of genes, so-called human leukocyte antigens, that regulate the compatibility between a patient, recipient, and his donor. Usually the best donor is a donor who is 100% compatible with the recipient. This means that the HLA typing, these human leukocyte antigens of the donor, are identical to the human leukocyte antigens of the recipient, of the patient. Today, this statement is not true anymore, because we know that we can perform the transplant also from a donor who is not 100% compatible with the recipient. There are specific techniques that allow this procedure. It is a little bit different procedure, a little bit different transplant, but today, and I will present you the data, we can do the transplant also from a partially matched family donor. So we have the donor, we have the patient, we give to the patient the conditioning regimen, this chemotherapy that usually lasts from 5 to 7 days. And after the chemotherapy administration, we have the transplant, the infusion of the stem cells collected from the donor, the infusion to the recipient using a central venous line. The stem cells are infused intravenously, and then we have a post-transplant period that is an important period. We can experience some complications. We have to wait for the engraftment, but during this period between the infusion of the stem cells and the engraftment, that usually lasts between 12 to 4 weeks, patients can have infections, can experience toxicity from the conditioning regimen, and can have hemorrhagic complications. So this period of so-called aplasia between the infusion of the stem cells and the engraftment of the stem cells is very important. And usually the patients stay in the hospital for the transplant for a median of 30 to 45 days. And then, if everything goes well, patients are discharged. We follow them in our outpatient unit at the beginning twice weekly, and then after 2 or 3 months, once weekly, and then the frequency of the controls in the outpatient unit decreases. So if this is a general picture of the transplant procedure, we must start from the donor. So the best donor is a so-called matched family donor. What means matched family donor? Is a brother or a sister, a sibling, who is HLA identical to the recipient. A donor can be also a carrier of sickle cell anemia, an heterozygous subject, an heterozygous sibling. This is a good donor as well. And the identity of the HLA typing makes it a perfect donor. Unfortunately, the probability of having a matched family donor is quite low, because the probability that two siblings are HLA identical is just 25%. So in the majority of cases, we have to search for a matched and related donor. In all countries worldwide, there are registries of voluntary stem cell donors that are willing to donate. So if we don't have a matched family donor within the family, matched an HLA identical sibling, we can start the search of a matched and related donor worldwide. Again, it is not so easy to find a matched and related donor, because again, we must have a very good degree of compatibility between the donor and the recipient, if possible 100% compatibility. So unfortunately, so far, in the majority of cases, it was not possible for children or adolescents or young adults affected by sickle cell anemia to go to the transplant because of the lack of a matched donor, of a compatible donor. More recently, several techniques have been developed in order to be able to perform the transplant, also using a partially matched family donor. What does partially matched family donor means? It means a family donor, usually the father or the mother, if we are talking about pediatric patient, about children, or a partially matched brother or sister. And in this case, a specific approach has been developed in order to allow the transplant also from a donor that is compatible just for 50%, let's say, of the HLA antigens I was talking some minutes ago. This approach of a transplant from a partially matched family donor is so-called haploidentical transplant. That means a transplant from a donor who is 50% compatible. Is not recent. It was developed several years ago, initially for patients affected by leukemia, and over time the results improved significantly, and nowadays, and I will show you the results, we know that a transplant from a haploidentical donor, a transplant from a partially matched family donor, can give results that are superimposable to that of a matched unrelated donor. The technique to perform the transplant is slightly different, but the results are really similar, and I will show you them. The next point, this is a difficult slide, but just to give you an idea of this topic. We have, as I said before, with the transplant, we need to achieve the engraftment of the donor cells. Nevertheless, we don't need to achieve 100% donor engraftment in the transplants for sickle cell anemia or for thalassemia or hemoglobinopathies in general. We know that also a partial engraftment of the donor cells can be sufficient to completely cure the disease. And this is very important because the possibility to cure sickle cell anemia also with a partial but stable over time engraftment of donor cells allows us to use a conditioning regimen, a combination of chemotherapy before the transplant that is less intensive, and this means also less toxic with less side effects than the conditioning regimen that we usually use, for example, for leukemia. So in a condition such as sickle cell anemia, it is not necessary. Of course, it is better if you can achieve a 100% donor engraftment, but it is not necessary to obtain a 100% donor engraftment. Also a 50 or 60, 70% donor engraftment is enough to cure the disease. And this allows us to use a less intensive and less toxic conditioning regimen. And this is an important point. So, which is the state of the art? As I said, if we had a matched sibling donor, a 100% sibling donor, the results of the transplant are very good. These are two very big studies, including more than 1,000 patients, that can show you that the probability of survival and event-free survival after transplant from a matched sibling donor are between, the probability of cure is between 90 and 100%. We know that age of the patient is important. In fact, as you can see here, if children are transplanted from a matched sibling donor when they are younger than 5 years of age, in this study, the authors reported a survival probability of 100%, but the survival probability progressively decreases with the increasing age of the patient. It is 95% for children and young adolescents, and it is a little bit less than 90% with adolescents or young adults. This is the state of the art from matched unrelated donors, so for transplants performed from a donor outside the family. And again, in this case, the most important factor for a good result is the degree, the level of compatibility between donor and recipient. As you can see, if you have a donor that is 100% compatible, he is 10 out of 10 HLA antigens identical, we have a probability of survival in the order of more than 95%. But the probability of survival decreases if we have a donor that is not 100% compatible. So an open problem with match unrelated donor transplants is that the probability of finding a 100% compatible donor is not so high. In some cases, is less than 50 or less than 20%. So this first transplant from a family donor can be applied only in the minority of patients who have a matched family donor, a brother, a sibling, a matched sibling, and that the probability of finding a matched unrelated donor is not very high in several cases. So this just to summarize this first part of the presentation. Where do we stand now with the stem cell transplant for sickle cell anemia? We know that we have a very good disease-free survival, a very good probability of complete cure if the transplant is performed with a matched family donor, more than 95% probability of complete cure. And we know that we have a low transplant-related mortality. Nevertheless, if we move from a matched family donor, from a matched sibling transplant to a matched unrelated donor transplant, we have a higher rejection rate, especially if we use a donor who is not 100% compatible. But the good news is that we don't need to achieve a 100% chimerism to cure the disease. Also a stable mixed chimerism, a mixed chimerism that is stable over time, can cure the disease. So what do we need now? We need to be able to offer an early stem cell transplantation also for patients lacking a matched family donor. And we need to improve our results with alternative donors, especially we need to decrease the graft loss, the risk of graft rejection and of graft loss. So we can consider a matched sibling donor transplant as a standard of care procedure for children affected by sickle cell anemia. We now have transplanted more than 1,000 patients, and mostly children. And as I said, the disease-free survival reported in the literature is at least 90%. We have a rejection rate that is very, very, very low, and also the transplant-related mortality that is low. Age, in the context of matched sibling donor transplants, plays an important role. If we consider children transplanted when they are younger than 5 years of age, we have a 100% survival probability. But if we consider adolescents or young adults older than 15 years of age, the probability of survival decreases from 100% to 95% to 88%. So age is still important for the transplant of this disease. And we have some unmet needs. Outcomes are very good in children and in infants, but they are not so good in older patients. The majority of patients do not have a matched sibling donor, and it is difficult to find a 10 out of 10 matched unrelated donors. So can in haploidentical transplant, so a transplant performed from a partially matched family donor, be a solution? Well, the answer is probably well, yes. This is one of the different studies published and the different experiences published in the most recent literature. This is a study of a cooperative group of Germany, London, and Paris. And as you can see, the approach is a little bit more complicated than a conventional transplant. We have to prepare our patients very carefully. They have to receive a hypertransfusion regimen for at least 2 months before the transplant. They must receive hydroxyurea at least for 2 months before the transplant, and in addition, they must receive also an immunosuppressive treatment before the transplant. The conditioning regimen includes several drugs such as tiotepa, fludarabine, antithymocyte globulin, and cyclophosphamide, and there is a specific immunosuppressive therapy after the transplant in order to prevent immunological complications after the transplant. Nevertheless, even if this approach is more complicated than a conventional transplant from an identical donor, the results on the first patient transplanted are very good, because we have in this series of 14 or 15 patients an overall survival of 100%, and in event-free survival. Event-free survival is survival disease-free, so without signs or symptoms of sickle cell anemia. That is in the order of 95%. So the transplant using a partially matched family donor is feasible. This is another experience with a slightly different approach. Again, we have 14 patients transplanted from a partially matched family donor compared to patients transplanted with a matched sibling, and the continuous line is the curve of the mismatched, the partially matched donors, and the dotted line that of the matched transplant. And as you can see, the probability of survival is identical, as well as that of survival without disease and of other complications. So an approach like this is certainly feasible, and with the results that are comparable to that of to those of transplant from a matched donors. And there is also a prospective study on stem cell transplantation using a partially matched family donor that is currently running in Europe. In this case, the approach is a little bit different. We use a selection of the stem cells before the transplant. That means that we collect the stem cell from the donor. We physically remove from the stem cells of the donor some subtypes of cells that can give immunological complications after the transplant, such as graft-versus-host disease, and the infusion consists of infusion of a purified stem cells, and this approach is effective too. Even we have this 24 patients out of 24 patients that have a full engraftment, that have a complete donor chimerism without or with a very, very low incidence of immunological complication after the transplant, and can be considered as cured from the disease. So this is my last slide. Allogeneic stem cell transplantation is a procedure that is effective in curing patients affected by sickle cell anemia. Currently we have different strategies. We have the possibility to perform the transplant from a matched sibling donor, and this is the most conventional transplant, and in my view, this type of transplant should be performed very early, if possible, within 5 years of age of the patient, and certainly before 10 years of age of the patient, because in very young children, this is the approach that gives the best probability of success, or more than 95%. But for patients lacking a matched sibling donor, we can start the search of a matched unrelated donor, and the results of a transplant with this type of donor, if the donor is 100% matched, are similar to those of a transplant from a sibling donor, from a matched sibling donor. The haploidentical transplant, the transplant performed from a partially matched family donor, a parent or a partially matched brother, has become in the more recent years a very effective procedure. There are at least 2 or 3 different techniques that make this procedure feasible with very good results. We do have a big experience in haploidentical transplants for other diseases such as non-malignant disorders, and this approach of a transplant from a haploidentical donor has been demonstrated to be effective also in the setting of sickle cell anemia. Again, the age plays an important role. The transplant gives better results if it is performed in children or in adolescents. It can be performed also in adults, but the clinical course of the transplant can be more complicated. So as a physician involved in stem cell transplantation, as I can say, my experience and the experience of my colleagues is that either is feasible, and in my view, it should be proposed to children or adolescents. It can be performed also in adults, in experienced centers, but the best results can be achieved in younger patients. So, as shown in an experience presented before, we don't have to wait too much. Even if we don't have a met sibling donor, the transplant can be done in different ways, also from partially matched family donor. And considering children, all children have a father or the mother then who can donate for them. So my suggestion is not to wait too much and to discuss the indication to the transplant with the physicians, with the physicians involved in the management of sickle cell anemia, with the physicians involved in the stem cell transplantation, because the results can be very good if the transplant is performed in an experienced center that is used to perform transplant in sickle cell anemia. Thank you.
Thank you so much for that, Professor Zeka. So, Subhana, are you still here? I see you still here.
Yes, it now is quite a good time to open the floor for questions to all of us, our specialists here. I mean, all of our experts here, both Luce, Marco, and Constant. It'd be really good to have people sharing their own life experiences about sickle cell. We start with Naomi, who has raised her hand. Can you just, Naomi, you're on mute. Could you just introduce yourself, say who you are, and ask your question?
Hello, can you hear me?
Yeah.
Okay, sorry, my daughter's just calling me. 1 second. Thank you very much, Dr. Marco, for that lovely presentation. And I'd like to also congratulate you for an amazing success story for what you've been doing, and your colleagues as well, for everyone who's also benefited from the treatment. I congratulate them as well. So my question is this, you had said that it's best to have this treatment for children from 0 to 5. And I understand from your presentation that it's quite difficult to get a match. So how do you, looking forward in future, how is this going to work? How is it going to be possible for children to get this treatment if it's difficult to get a donor to match with them? What steps are you taking, to try and get people to be comfortable to sign up to be donors and want to help people or children with sickle cell?
Sorry. Thank you for your question. Yes, as I said, it is the results are better for younger patients. But in my experience, we have transplanted with good results also adolescents and young adults. I think that the oldest patients patient we have transplanted in our center, in our unit, and affected by sickle cell anemia was 26-year-old, if I remember well, and she's doing fine. Nevertheless, transplant in younger patients give better results. This is not true only in sickle cell anemia. The results are better in children and in younger patients for all diseases. This for several reasons. So there is a better coexistence of the donor and the recipient. If the recipient is young, the recipient has less toxicity, and especially for sickle cell anemia, where the disease can worsen over time, where we can have organ damage such as cerebral vasculopathy or pulmonary hypertension or chronic kidney damage. If we do the transplant before this complication appears, it is better. It is better. Our approach is usually to start to do the HLA typing to verify if we have a patient, a family donor, a sibling who is compatible, and to start the search for an unrelated donor, even if we know that the probability of finding a 10 out of 10 donor, as I said, for several people is less than 20%. The other possible approach that I described is to perform the transplant from a haploidentical donor. Usually we can use the father or the mother as donor. And as I said, for sickle cell anemia, this is a quite innovative approach because it has been used in the last 5 years more regularly. But in the context of other diseases, such as neoplastic diseases such as leukemia, the experience with the haploidentical transplant is let's say a 10 or 20 years experience. And over the last years, we have developed very good results also with the transplant from a partially matched family donor. So I think that the transplant from a haploidentical donor, haploidentical means that the donor is only 50% identical to the recipient. This strategy can be used. This strategy is effective. And this strategy is effective, especially if the transplant is performed in children or young adolescents. It can be used also in young adults, even if it is a little bit complicated. What I would suggest is that this approach should be used in centers with a long-lasting experience of transplant, because it is a little bit different and a little bit more complicated as compared to a more conventional transplant. So I would suggest to ask the physician to refer patients who are interested in this approach to a transplant center where there is experience and in this specific procedure.
Thank you very much, Marco, for that. There's another hand up from Janine, but before we move to Janine's question, there's a very interesting comment made after Constance's talk by Adrienne, who says the moving testimonial from Constance highlights the huge pressure on parents who are responsible for the final decision. So we've just been talking about the use of fully matched sort of myeloablative donor transplants from at a much younger age to provide the maximum success rate. But that decision, I think, is a very heavy burden of decision making for the family, for the parents, and of course, you know, the importance of not just sharing information for the parent, but also with the child is so important, as mentioned so clearly by Constance. So I guess for people here who have either, and of course, Constance himself has been through the journey of being a parent whose child has undergone a transplant. Is there anybody else in this audience today who would like to share their experience of having to take that burden of responsibility of decision making and considering the weighing up the benefits and the side effects of transplant. Is there anybody here who would like to share their thoughts or anything like that?
I'm not sure whether Janine's hand is up, whether it's a related question. If was somebody about to share that to answer Sabana's question?
Maybe I can add one consideration. I think that I completely agree that it is not an easy choice to decide to go for a transplant from an alternative donor. What I think is that it is a decision that must be shared among the different parts, the different actors, among the parents, the physicians who are curing the patients with the medical treatment, and the transplanters. I think that the parents and the patient must receive an appropriate and as extensive as possible presentation of the pros and the cons of the transplant. And I think also that the results of the transplant have improved very fast over time. And I would say during the last 5 years. 10 years ago, an haploidentical transplant was performed just for leukemia, and not all patients with leukemia, just patients with leukemia with the most severe and most aggressive form of disease. But during the last 5 to 10 years, several different approaches for haploidentical transplant have been developed, and currently, I must say, in my institution, at least 1/3 of the transplant we perform per year is performed from a partially matched family donor. So it is not an experimental treatment. It's a treatment that is routinely used with very good results for different type of diseases. So it is important that the decision is shared between the family and the physicians.
So, Marco,
can I just add to that as well? Sorry, Sabana. Can I just add to that as well? I think as a parent who's gone through similar situation with Constant, the information sharing is good, but I think the psychological part of the family as well is very important. For our experience there, it took us 2 years to agree. You have to weigh the benefits, the risk and benefits of the child. For example, if you do the bone marrow transplant, as opposed to like our daughter went through similar situations with Luz, where everything failed. And when she did the red cell exchange, we saw that at some point we had to decide whether is this what we want for her for the rest of our life, because there's also antibodies and them, or do we want to go through the risky procedure knowing that we've ticked that box to say anything can happen. But I think being prepared as families psychologically, we had to go through therapy. And at the end of the day, ultimately, it was our daughter's decision to accept to go through that process. But sharing that information to know all that is needed with the physicians is very important. And that really helped us to actually go through and make that decision for her to undergo the transplant.
And another point I would like to add is that I think that the preparation before the transplant is very important. We don't need to do the transplant in a hurry. For me, it is not an emergency procedure in the setting of sickle cell anemia. So we have a similar experience with the thalassemia. The better the patients arrive to the transplant, the better are the results. So I think that patients must be carefully prepared to the transplant. If necessary, they must receive erythro exchange procedures before the transplant or hypertransfusion. We must control the infections and so on. We don't need to decide to go to the transplant in a week or in 2 weeks. So we have some months before the transplant in order to be to arrive to the transplant with the best condition we can achieve. And this is very important for the outcome.
Thank you.
We have Janine's mic has been up for a while. Sorry, so go ahead, Sabine.
Can I speak now?
Yes,
you can go ahead.
please go ahead.
Okay, I have a comment and a question. My comment was, to share your experience with the bone marrow transplant process. So when I was a kid, I did go through the process, but this was over 10 years ago now. It's come a long way. And at the time, it was just me and my dad, and we was given a lot of information in one day. I did a lot of blood tests in the same day, and we didn't get a lot of support to make the decision. And at the time, it was just the two of us. It was too difficult for us to go through it, just us two. So we ended up not going through that process. And also I didn't have any 100% donors in my family at the time, which was a very big point. And yeah, it was quite a stressful process because we didn't have any psychological support like you did with your daughter and your family, which sounds amazing. And I'm so glad the process has come such a long way and families are getting more support. I just wanted to share that little comment. And I also wanted to ask Dr. Marco about, I've been seeing and reading a lot lately about CRISPR gene editing, and wondering if that could take over from donor gene therapy in sickle cell in the future for a cure that could maybe be safer or be more available to more patients. Thank you.
Well, that's a very good question. Of course, gene editing is still an experimental treatment. And even though I must admit that it is very promising, I don't think that there is a competition between the two treatments, between stem cell transplantation and gene therapy or gene editing. I think that we will find different indications. Also, gene editing requires a chemotherapy before the transplant. Requires the administration of high-dose chemotherapy of the so-called conditioning regimen, and with the possible side effects. While on the contrary, there is no risk of immunological complications such as graft versus host disease, because gene editing is performed using autologous cells. We still don't know the possible long-term side effects and the long-term efficacy of gene editing, as it is a procedure that is available within prospective clinical trials that has been available in the last 3 to 4 years. So we still have to understand better the safety, especially on the long term, of gene therapy and gene editing. I think that for very young patients, the results of the current results of stem cell transplantation are very good, and are in the order of 90% or more. So I think that on the short term, it will not be possible to further improve these results, for example, for gene therapy or gene editing. On the contrary, if we consider older patients, if we consider adolescents or young adults, where the transplant is characterized by less good results and is characterized by more toxicity and more and the higher incidence of immunological complications such as graft versus host disease. In this setting of adults or young adults, gene editing could be a safer procedure and with very good results. So in my opinion, in my view, in the next years, probably we will learn to understand in which patients a stem cell transplantation from a haploidentical donor or an unrelated donor is more effective, and which patients have an indication to gene therapy or gene editing. But I think that they are complementary. They are not mutually exclusive. We must learn which strategy is the best for every single patient.
Thank you.
We have
Clara,
a question in the chat box. Yes, I thought
Clara
you were
has
going
her
to
hand up. Clara has had her hand up for a bit. Clara, do you have a question?
Yeah, I have a question. Thank you, Dr. Zika. I think you have answered my question with your previous answer, actually. But still, I'm Clara Faye. I'm a certified coach, and I have been helping some patients newly healed with the transplants, with the haploidentical transplant, actually, because of the identity crisis that they went through. And I've been working with Luz that I've been speaking just previously. My question is about the specific case of the adults and the transplants. There is some adults that have never heard about haploidentical transplant. There are a lot, actually. And still, some adults just realize that they have some haploidentical compatibility with some siblings, but they are adults, and of course the risks are higher. So my question was about what would you recommend for the adults who are a very severe case of disease and discover that they can have some compatible donors, even if it's still less easy than for the children? What will you recommend to them?
A very good and very difficult question, I know. I say I would recommend to discuss their cases together with their physician and the physician of the transplant team. As I said, a haploidentical transplant is a procedure that has become over the years more safe and currently is routinely performed both in children and in adults. I think that the evaluation of the indication to an haploidentical transplant must be carefully performed for every patient. So we must consider the risks, also the organ damage, as I mentioned before, the pulmonary hypertension of the kidney failure. I think that if a young adult doesn't have severe complications, he or she should be evaluated for an haploidentical transplant, especially if the donor is a sibling, so it is reasonably young, and if the recipient does severe or end-stage organ problems. There are different approaches to perform a haploidentical transplant. We have a so-called T-replete strategy using a more aggressive immunosuppression after the transplant. But we have also a T-cell depleted strategy, the last one I showed, where there is the physical removal of a subset of T lymphocytes that can cause graft versus host disease. This second platform is the graft versus host disease. So it is a safe procedure. So I don't think that we should say, no, you are too old for an haploidentical transplant. I think that we must evaluate the level of compatibility. We must evaluate the age of the patient and the donor, the clinical conditions of the recipient. We must also evaluate if with a proper management of the disease for, let's say, 6 months or 1 year with a chronic transfusion regimen, or currently there are several new drugs that we will be able to use in the next year. If a proper management of the disease for 6 months or 1 year can improve the clinical condition and can make the patient fit for a transplant. But I wouldn't say, no, you are too old for a transplant.
So would you say there's no cutoff date? Just adding on to, there's a question in the chat box talking about the age of the adult patients. Mm-hmm. There's not necessarily a cutoff date. Does it just look at the clinical presentation?
Sorry, I don't know if I understood well your question. You were asking if there is a specific cutoff date, cutoff of
yes,
age.
There's a question in the chat box. Yeah, it's just following up because you are discussing date and age. Sorry. So there's a question about the cutoff age for adults to have transplants.
Well, as I said, usually most transplants in adults are performed in patients that are younger than 40 years of age. We have an experience up to 25, 26 years. The problem is that with the older patients, it is not just a matter of age. I think it is a matter of the conditions of the patients. I think that if patients have a severe pulmonary hypertension, or they have a significant impairment of kidney function, this could be a contraindication for the transplant, because the risk of transplant-related toxicity and transplant-related mortality would be very, very high.
Have a hand by Francois.
Okay, excuse me. Good afternoon. I was not on the first part of the discussion, but concerning the transplantation for adult patients, we have to mention that with the NIH protocol using alemtuzumab and low dose of TBI and sirolimus for the chronic GVHD prevention, the results are very, very interesting for adult patients, since 87% of them have been cured. They observed only a risk of rejection, but no GVHD at all, and no death related to transplantation. So it's a real important progress for adults with HLA matched sibling donor. So now it's really possible, even in adults with organ damage, to go to the transplant, and when they have a matched sibling donor. And there is also the other possibility with haploidentical donor, as you have explained. So now all sickle cell disease patients have access to transplant, since everybody has a haploidentical donor, since mother or father or one half of siblings are haploidentical donor. So it's a real progress. And until gene therapy will be enough accessible, it's important to consider these kinds of transplants for sickle cell disease patients. Thank you.
Oh, thank you, Françoise, because I agree with you, and it is what I try to explain in my presentation, that in my opinion, currently, we must not say that we can't perform the transplant if we don't have a matched sibling donor, because the transplant can be performed using a matched sibling donor if available in the minority of cases. We can, if we have a 100% matched unrelated donor, we can use an unrelated donor if the donor is 10 out of 10. And I wouldn't use a completely matched unrelated donor because of a high risk of rejection or a high risk of graft versus host disease. And I agree with you that the results of transplant using a haploidentical donor are very interesting, are very good, have significantly improved during the last 5 years, and that we have these different approaches, T-cell replete or T-cell depleted approaches, to perform the transplant from a haploidentical donor with very good results.
Okay.
Even if I added that this approach should be, I think that should be reserved to centers with experience in haploidentical transplants, with experience in transplant in sickle cell anemia, and if possible within a prospective trial. I wouldn't suggest to perform an haploidentical transplant in centers where there is no experience for sickle cell anemia or very low experience for haplotransplants.
Sure. Okay, thanks.
Can I ask a question to Luz? This is like an experience when you went through the transplant. Would you, I know you've given a testimony of what you went through psychologically and the disease process, but during the treatment itself, are you available? I mean, are you ready to share, or do you sort of remember what you went through in terms of, you know, the chemotherapy and all, and the body, comparing to how, you know, when you are unwell, having a sickle cell crisis, the pain, but when you're going through the chemotherapy and the process, would you describe, if it's, you know, easy to describe how you felt during that treatment?
Yeah. I was very anxious, like I said avant. But I was also in crisis when I was in the sterile room. I have a crisis pain, but even if they say a lot of transfusion before, I still have a crisis pain. It doesn't change. The only thing is changed about crisis pain is the GVHD. Every day you have a new comment dire, une nouvelle. Enfin, avec les GVH, tous les jours, il se passe quelque chose. On a des réactions à la chimio, on a des réactions. Moi, il m'est arrivé plusieurs réactions différentes à cause des GVH. C'était ça le pire.
Yeah, so she's saying that the worst part was having every day a new reaction, or a reaction she wasn't expecting, different from the previous day, and that was a very difficult part to handle with.
Also, it's a psychologic moment where you have to already I was praying every day, because it was hard to be in a sterile room. You can go out. I stay in the sterile room 2 months, And if I don't have a mindset to stay in the same room, you can have a panic crisis. You live dans une espèce de cage et c'est très compliqué à vivre au quotidien.
Yes, you live like felt closed in a cage, and it's very difficult to daily cope with this claustrophobic sensation.
Yes. Only the GVH and the secondary effect of chemotherapy, the pain crisis was a été bien pris en charge. Les crises douloureuses ont été bien prises en charge par le service.
The painful crises were very well taken, followed in the hospital.
Mais par rapport à tout ce que j'ai vécu, c'était pas. Si c'était à refaire, je le referais parce que les crises successives de douleur, c'était beaucoup plus intense que juste 2 mois en chambre stérile, en fait. Enfin, ça valait le coup. Ça valait le coup de vivre tout ça, même les GVH.
So she's saying that even all the side effects she was facing, she would retake the same decision of performing the transplant, because even if in that moment it was very difficult, but then the effort is very well repaid, I will say. J'ai manqué de dire quelque chose ou ça va?
Non, non.
Ça va?
Okay. Merci. Je ne sais pas si j'ai répondu à la question. Mais...
Oui, tout à fait.
Okay.
Well, can I add the consideration to Lou's observations? Yes, I know I said that the transplant is a complex procedure, and this is the reason why I think I'm convinced that the decision to go for the transplant must be shared between the patient and between the physicians, and that the patients must receive exhaustive information on the transplant procedure. What we know is that there can be some difficult days after the transplant, and it is even more difficult for patients with sickle cell anemia, because every day is a new day, and they don't know what receiving chemotherapy means, and they don't know what let's say losing the hair means, and so on. But I think that all these problems, if they are faced together, the patient and the physician or the family, they can be solved day by day. And I think that it is really important that there is a very, very good discussion, a very good talk between patients and the physicians and the family. And if there is a good sharing of the different aspects of the transplant, I think that every problem can be solved.
Just ask another question from a clinician point of view. You know, there's this notion where you can only do a transplant if your disease process has deteriorated and you've got no other option. But on the other hand, we are saying that when there's a lot of organ damage, you are at risk of having a lot of complications. Do you, as clinicians, accept where a parent comes to you and say, I've got a sibling donor? Because like for me, we knew from the time our daughter was diagnosed that our third child was a match, but it was us who took 10 years to make that decision because we saw somebody die after having a transplant. But if I decided, for example, from about 5 years, she was perfect, she was fine, I come to you and I say, I want my daughter to have a transplant. would you accept? Because what I've seen or what I've read is you would rather somebody goes through all these, crises and other options fail, then you come to the transplant. But then if they've got a lot of organ damage, there are tricks. So where is the balance?
Well, that is a very good question, and I think that is the central question of the talk of this afternoon. Well, I think that if we have a sibling donor, the transplant should be offered to almost everybody, because even if a patient is doing very well when he's a child, when he's a baby, we know that the clinical course of the disease is unpredictable. So we can have children that are doing very well, they are very young, and then complications appears during when they get older. So I would say that there is an indication to the transplant at the very first signs of complications. So we don't have to wait for the appearance of severe cerebral vasculopathy. We don't have to have osteonecrosis before giving the indication to the transplant. I think that if a patient is doing well with hydroxyurea and he lacks a matched sibling donor, maybe he can continue with the hydroxyurea. But if the patient has a clinical picture that is not controlled with hydroxyurea, if we have a patient with cerebral vasculopathy who must start a chronic transfusion regimen, this is a candidate to a transplant before he develops severe, long-lasting or irreversible size complications. So I would say that we must switch from an indication to the transplant when we have the most severe cases, and we should move to give the indication to the transplant when we see that with hydroxyurea the control of the disease is not optimal.
Thank you. I totally agree with what you said. But we would like to add that the problem that familial HLA typing is not enough performed in sickle cell disease centers. This should be almost automatically performed because the patients do not know if they have sibling available donor, and only in the transplant unit, but it's different in the sickle cell disease centers. HLA typing is not sufficiently performed.
Yes, I totally agree. I must say that when you have a new diagnosis of sickle cell anemia, the first thing you have to do is to start hydroxyurea and the proper medical treatment. But at the same time, you should perform the HLA typing to see if you have a matched sibling donor or if there is a chance to have to find an unrelated donor, at least to perform a preliminary search to understand if the HLA typing is common or rare. So I totally agree that, and also in my experience, in the experience of our center in Italy, it happens to receive patients for the first time when they are 10 or 15 years old, and to discover that they have a matched sibling donor who is healthy, and that maybe they could have been transplanted 5 years earlier if the physician had performed the HLA typing. So I totally agree with Françoise. It should be performed at time of diagnosis.
Yeah. That was offered to us. For us, everything went wrong. So the only option, I think, the doctors gave us, at least there was light at the end of the tunnel, because everything was messed up for us. So as a family, our children were tested with the time that she was diagnosed, and we are offered if we could do the transplant because our presentation was nasty with the acute chest syndrome. but we, for whatever reasons, like we couldn't go through with the transplant from the beginning. So we knew that our third child was a donor for 10 years until we were at the place as a family to go through the treatment. So that's why I was saying, like, if I'd known and my daughter was okay, if I just say, I've got the money, I want my child to have a bone marrow transplant, would the doctor say yes without having the complications?
The other thing that I would like to say that for patients with cerebral vasculopathy are those with severe anemia and are not the patients who experience very frequent crisis. Often they are anemic and they are slowly, but sometimes they are not hospitalized for vaso-occlusive crisis. And these patients have very severe sickle cell disease. So it's really, really important to perform a transcranial Doppler, but also systematically MRI, MRA to detect cerebral vasculopathy, because cerebral vasculopathy is the crucial, often the most important indication for stem cell transplantation.
Yes, and if I remember well, a paper of yours, children with the lowest hemoglobin at time of diagnosis are those with a high risk of develop severe vasculopathy. So if we have a child where we diagnose sickle cell anemia and he has 7 grams per deciliter of hemoglobin, this is a very high patient with a very high risk of developing severe vasculopathy. So he should be a candidate to an early transplant.
Mm-hmm. Sure. Okay.
Thank you. Are there any other questions or any contributions?
Can I just
ask? Can I quickly ask one question, please? Just a quick one. And because I suffer from sickle cell SC, and my experience is that sometimes treatment meant for SS and the other variants may not be applicable to me. For example, I tried hydroxyurea, but I didn't, cope well with it, so I had to go on exchange program. So with this transplant, does it can it be used for all sickle cell types, or is it for a particular sickle cell type? That would be my question. That's okay. Thank you.
Okay, thank you for your question. No, the transplant can be used for every subtype of sickle cell disease. I think that generally speaking, the transplant is not a very sophisticated treatment. I mean, we just try to destroy all the defective stem cells independently of the type of genetic defect, of the type of disease, and we replace them with healthy stem cells. So certainly gene therapy or gene editing will be much more sophisticated approaches, but the procedure is effective in SS sickle cell disease, or SC sickle cell disease, or S beta sickle cell disease, because the concept is the replacement of a defective hematopoietic system with a hematopoietic system of a healthy donor.
Got it. Thank you very much, Dr. Zika. Thank you.
Sometimes when I explain the procedure and I say that it is not very sophisticated, I use this example. In your kitchen, you have the dishwasher that is not working, and with the stem cell transplant, you substitute, you change all the kitchen to repair the dishwasher. So it doesn't matter if what is not working is the dishwasher or the oven or something else. You replace all the bone marrow with the stem cells, so you can correct, you can repair the different genetic defects that are at the basis of the disease.
So, as said Professor Lucarelli, the allogenic stem cell transplantation is the total successful gene therapy.
Yeah.
I heard this.
Can I also, another question in terms of fertility issues? I've got two questions actually in terms of that. Firstly, I've read of bone marrow transplants where you don't use the chemotherapy. I was just trying to research. I've read it somewhere. There's an agent you use with radiotherapy that preserves the fertility of a patient. It's not very much discussed, and there's no much literature. Would you discuss or would you comment on that? Because I know a child in the US who did this. I had somebody I was speaking to when we compared our daughter, they had to store her tissue for, the ovary tissue. And she said, oh, my daughter, they didn't because they use this agent with radiotherapy, which doesn't affect fertility. I'm sure you know what I'm talking about. There's a process for that. Would you comment on that?
Yes, this is a very important question and a very important topic. I think that generally speaking, whenever possible, a strategy of preservation of fertility should be adopted before the transplant. For male patient, this is more difficult because you can cryopreserve the spermatozoa just in adolescent patients or in adult patients. In girls, you can collect also part of the ovary tissue also in prepubertal girls, in prepubertal children, and this approach has been demonstrated to be effective and can be used also in children before puberty, while in the males a strategy of preservation of fertility can be used only after the pubertal development. But it is a topic that must be taken into account, and I think that it should be performed whenever possible. As far as the impact of the conditioning regimen is concerned, there are strategies to reduce the impact, the damage on the testis or on the ovary by the conditioning regimen. And in the setting of sickle cell anemia and non-malignant disorders, we have tried over time to optimize the conditioning regimen with the aim of trying to preserve fertility. Some drugs, such as busulfan, are more toxic on the ovary or on the testis than other drugs, such as triosulfan or, as you mentioned, low-dose radiotherapy. So the physicians involved in the transplant, in the stem cell transplantation, are actively trying to find new strategies in order to preserve fertility after the transplant. And for example, a drug such as triosulfan is less toxic, and it has been demonstrated to have a significantly lower impact on fertility than other drugs such as busulfan. And so several centers are trying to move from busulfan to triosulfan in order to have a lower long-term side effects. And there are different reduced intensity conditioning regimens. You mentioned some conditioning regimens, including low-dose total body radiation, that have the aim of reducing short-term and long-term toxicity, and in this way reducing the risk of the sterility. Of course, a reduced intensity conditioning regimen has two sides. One side is if I decrease the intensity of the conditioning regimen, I decrease the risk of acute toxicity and long-term side effects. But I also increase the risk of poor engraftment of graft rejection or of late marrow failure. So every new conditioning regimen should be tested and properly evaluated in order to carefully balance between the pros, the reduced toxicity, and the cons, the increased risk of rejection. But we can, several conditioning regimens currently used can avoid the risk of losing fertility.
Yes, please go ahead.
Concerning the fertility, first, for the girls who have been transplanted 15 to 20 years ago, spontaneous pregnancies occurred.
Yes.
So this it's important to consider. There is some reversibility of ovarian failure possible, but after a very long term following stem cell transplantation. But now it's really important. We have the possibility to cryopreserve ovarian fragments, so it's really important. And now for the young boys also, it's possible to cryopreserve a tissue, a testis tissue before transplantation. So there are, we increase the chance to have children following a stem cell transplantation, and it's really important before considering this therapy. And we have to keep in mind that busulfan, the drug which is toxic for ovary, is used also for gene therapy. So yes, this is not there. We have to say this again. So it's the same problem with the gene therapy for the moment, considering the risk of sterility.
One thing I maybe would like to return to was Luce's comment about, and I think also Clara, both of you I know have worked together about this with an older person's experience of no longer having sickle cell disease after you've had your transplant, and how you get into terms with your kind of new identity, and how difficult it is. I thought that your comments on that was really interesting, Luce. Either Luce or Clara, do you want to elaborate a little bit on your experience of you working? I know you do some coaching as well, Clara. Do you want to talk a little bit about that?
Yeah, so you have a question about how is it to help patients with an identity crisis after the transplant?
Yeah.
Okay, so in fact, after the transplant, what Luce said was that something bursted, her bubble bursted, because she had a previous identity in a survival mode. And the survival mode included not being in touch with her emotions, being able to isolate herself from so many issues that was around her. And she had a lot of systems to protect herself. So when we have been working with Luce to overcome this challenge, to be trapped in the identity of someone who is still sick, we had to question the basic things. Who am I besides this disease? And what do I want? And how can I create my life vision for myself So this was a very challenging process, but still it was also a process of beauty, because discovering yourself and being able to taste so many things for the first time, for me it was also a way to see rebirth somehow. So this process has been full of challenges and full also of beauty. And I think that following those patients and helping them to find themselves was also a way to give them back their power to create their own identity, to take power in their life. And the main work was about changing the belief about the fact that you can't do so many things. You are not able, you are not capable, you are not enough. The not enoughness was so much into this process. So just deconstruct those beliefs and changing those emotions and getting in touch with it was the heart of the process. I hope I answered the question.
You did very eloquently, thank you. I know Revi has a question as well, she's put her hand up, but can I just quickly ask you, in your experience, Clara, because older people, when they have already got a very stable identity of being who they are, and then suddenly have this life-changing treatment, at what stage of their transplant process do you think that this kind of conversations has to happen? Do you think we should prepare them in the beginning, or does it have to happen at the end?
Yes, it's a very interesting question. I really think that the sooner the better, because the fact that, and that's what we have been doing with Luz. Luz has been mentoring and me, I've been coaching the patients, but we have been working with them even before the transplant. And it has been interesting because it was also a way to prepare and to live also the process of transplanting, making it smoother, making it easier, making it not easy, of course, not nice and full of flowers, but still helping them to take control and accept their own decision, because still they are adults. It's not the same case that the children with the parents who have took the decision, and it's another process. You took the decision to get your transplant, but still you have this inner conflict within yourself. So our purpose in the before transplant is also to accept and to digest their own decisions, as well preparing. Yeah.
Thank you, Clara. That was really well answered. I'll take a comment from Marco and then we'll go to Revi.
No, maybe I can make an example of the organization in our unit. We have tried to have a so-called case manager nurse that starts to take care of a patient and of a family that at the very beginning of the path towards the transplant. So once a family or a patient is out on our waiting list for the transplant, there is a nurse, a person, the case manager nurse, that interacts with the family, and she accompanies the family through all the path to the transplant. So from she is present to every meeting with the physicians. She at the beginning, she's present at the first meeting with the psychologist, and the nurse accompanies the family during the transplant period. She works also in our transplant unit, so she can follow the patients also during their stay in the transplant unit and until the discharge. So I think that this could be an organization and model that could help the family and the patient during all this procedure.
I just wanted to say something. In this organization, if you need to have patients who have a transplant, because they can échanger. They can talk about exchange. So the thing you live, in fact, not something is not living a transplant can talk, but you don't understand if you don't live the transplant. You have to you need to have something who had a transplant can explain what is going in mind of people with transplant. Is the more important for me. That's why I say I do a program for that, because every time the doctor asks me to explain my story and to tell what is to live a transplant, because it's very difficult to. This process is so important. It is a changement of the identity of the disease. Don't let the place to the other shows only the pain. When the pain gone, what is left? And every I know the nurse are very kind and they can help, but you need someone to have living the process to do more than the nurse can do.
Thank you, please. Ravi, you have a comment, Ajipon?
Hi, everyone. My name is Reve Ejapon. I'm based here in Canada. I'm also a stem cell transplant patient for sickle. I was transplanted about 4 years ago, and I'm also a registered nurse working in pediatric hematology. I was just commenting on the question that was raised regarding, just the transition and things like that, going from someone who was sick to someone who is, I guess, seemingly more healthy now. I feel like that was actually, for me, one of the hardest adjustments, and one of the things that I feel like I was most ill prepared for when it came to transplant, just because, they talk to you about the nausea that you'll have, the headaches, the body pains you might experience, all of the physical things that might happen, and, some of the isolation. But I don't think I was prepared to kind of go through that shift where you're no longer a sickle cell disease patient, but then you're also not a cancer patient, but you're a transplant patient, but then you're also not quite healthy like everyone else. You fall into a very funny category where you're kind of alone. It almost felt more isolating to be there than to have sickle cell disease, because at least with sickle cell disease, you have a full community of people and doctors and nurses who understand exactly where you're at. But in this post sickle cell stem cell transplant world, there's very few of us, it seems. And so you're kind of left. And then you also do deal with a little bit, or at least I dealt with quite a bit of, in cancer, they would call it like survivor's guilt, that, you're happy that you made it to the other side and you're cured and you're quote unquote healthier now. But then it's hard to see that there are some people who don't have that sibling match donor. In my area, that's all they were doing for transplant. It was really hard to see that, and kind of wondering how you can bring the rest of the people so that they can also get that same type of relief and that same type of cure. But then at the same time, trying to just appreciate and be thankful and grateful to God that you have this opportunity. But I just wanted to chime in and add that comment.
That's really, really very insightful. Thank you, Rebecca, for sharing that. I think the last 2 hours has really gone by so quickly because it's been such an engaging, riveting conversation we've had with a room full of people and very engaged, fantastic questioning. I'm afraid our time is up. I think we'll probably have to close this conversation, but if anyone wants to hear a summary of it, firstly, this is going to be available on YouTube for future in the EuroBloodNet website, YouTube page, but we're also going to do a presentation later on tonight in the plenary session. So if anyone wants a summary of what's been spoken here, please do come to the plenary session. I will hand over to Agnes for final words before we close.
Well, this has been very insightful for me. Every day is a learning process for me as a parent who has a child who underwent this process. So I just want to thank everyone for the contribution. I know time is never enough. I was really going to ask Constant to speak again, but again, there's no time. But just thank you to the doctors and everyone who's participated. As we say, we can never learn enough. Every day there's a lot of information that's coming through, and it's very important discussions to have, and hopefully we have this again next year, ASCAT. Thank you so much. Over to you.